It's an exciting moment actually for immunotherapy in solid tumors. We have interesting data in non-small cell lung cancer, in melanoma, and we have the first data presented on triple-negative breast cancer with pembrolizumab, that is an anti-PD-1. We know very well that in breast cancer you have tumor-infiltrating lymphocytes, and we know also that when tumor-infiltrating lymphocytes are present, the prognosis of patients is better. So the idea to harness the immune system with immunocheckpoints inhibitors may bring to clinical benefit to the patients. If we know that non-lymphocyte predominant breast cancer have poor prognosis, if you give an immunocheckpoint inhibitors to a patient in order to improve the immune response, the hypothesis is that we will have responses in the metastatic setting and better prognosis maybe in the other settings. We have actually 2 clinical trials in breast cancer with immunocheckpoint inhibitor. The first one is a trial, a prospective trial in triple-negative breast cancer using pembrolizumab for patients with PD-L1 expression or no expression of PD-L1. This is a seminal trial because it will demonstrate if an immunocheckpoint inhibitors can change the prognosis of these patients. And the second trial is for patients with HER2-positive disease progressing to anti-HER2 therapy, in which you combine trastuzumab plus an anti-PD-1 agent. The hypothesis is that if you give an immunocheckpoint inhibitors, you will downregulate the T regulators, you will upregulate the CD8 cell, the T cytotoxics, and so you can enhance the immune response in the tumor. So these are the only trial ongoing. Then we have a lot of trials with the vaccination strategy. Not in the metastatic setting, just in the adjuvant after surgery. And there are interesting data of activity of these vaccines. That's why I believe that we need to move in the field of vaccination, at least in early breast cancer or in the setting of ductal carcinoma in situ. You should know that many patients with ductal carcinoma in situ receive tamoxifen if they are ER positive, because tamoxifen will reduce the risk of relapse in terms of in situ or invasive events. Think about a vaccination. So it's a completely different approach. You will save the side effects of the hormonal therapy, and you can give a vaccination directed against a specific neoepitope that maybe is expressed in the DCIS. I mentioned in my presentation the history of CRB2 positive DCIS. They are almost 10 to 15%, and in case they do not express estrogen receptor, vaccinating with the HER2 peptide can be a very reasonable option for these patients. So we dramatically need trials in this setting. I believe vaccination will change practice in the prevention setting, not for patients with cancer. If you think about vaccination against the human papillomavirus to prevent the carcinoma of the cervix, this is an example of a successful history of a vaccination. So in my opinion, if we discover a specific antigen that is overexpressed in a precancerous lesion and you vaccinate the patients, in my opinion, you will enhance the immune system, and that specific patient will not develop a tumor, an invasive tumor. So the landscape, in my opinion, will have an impact in precancerous lesions, not only in breast cancer, but also in other diseases.